Earlier this month, a patient told me something that stopped me in my tracks. She told me that her husband, who has rheumatoid arthritis for decades, his hands have deformities from years of inflammation. They're always swollen and so painful. Medications have really not helped him. And now he went for radiation, not cancer radiation, low-dose radiation for his hands. And after just a few treatments, his pain has really come down. And she thinks that the swelling has also gotten better. And then last week, another one of my patients told me that they had gone for low-dose radiation for their hands, and it really helped them. And yesterday I saw this woman who had just finished radiation treatment for her knee osteoarthritis. Radiation treatment for the joints is new, and it's not medication. So today we're going to talk about radiation, specifically low-dose radiation for the joints and tendons. What exactly is low-dose radiation? Who is it helping? Is it treating rheumatoid arthritis or other types of arthritis? And why is it suddenly showing up in American centers? I'm going to walk you through what we know, where the real data exists, where it's still evolving, and how this compares to other non-medication treatments for inflammatory conditions. I'm Dr. Neha. Let's dive in. Low-dose radiation therapy is given by a radiation oncologist, not a rheumatologist. It's an external beam. You don't feel it, there's no needles, there's no cutting, and it's usually done in short sessions, about 5 to 10 minutes, over a week or two. This is not cancer-level radiation. This dose is much lower. At low doses, radiation appears to calm down inflammatory cells locally. It may reduce certain immune signals and decrease the activity of those inflammatory white blood cells in that specific area. Think of it as turning down the volume on the immune system response in one location without affecting the rest of your body. That's the theory, and some clinical studies do support this idea. One important thing to know before we go on is that the studies are really in people over the age of 40 or 50. This is not really well studied in a 20-year-old athlete. It's generally in a more older, seasoned population. Now, I know the word radiation immediately triggers a question in your mind, and it should. We're going to get into the full safety picture later in this video, including some important history that you need to know. But here's a question I keep coming back to as a rheumatologist. When patients with rheumatoid arthritis say that this treatment has helped, what exactly did it help? Because the answer to that question changes everything. If you have rheumatoid arthritis or ankylosing spondylitis or lupus arthritis, you are still allowed to have osteoarthritis, plantar fasciitis, tendonitis. Bodies don't read textbooks. So when someone says that my RA improved after radiation, we have to ask, was it autoimmune inflammation? Was it degenerative arthritis pain? Was it tendon inflammation? Because these are different biological problems with different mechanisms. And this brings me back to the first two patients I mentioned at the very beginning. Why did the radiation help their hand pain? Most likely because that painful joint had overlap. Osteoarthritis plus tendonitis plus residual inflammation. RA joints are complex. All autoimmune joints actually have that complexity. Multiple things can be active at the same time. Low-dose radiation treatment may have calmed that local picture, even if it didn't really touch the underlying systemic disease. And this matters, especially for rheumatoid arthritis or any of the other autoimmune diseases, because they are systemic conditions. They don't live in just one joint. That would make it a little bit easier to treat, I think. In RA, for example, it typically affects small joints of the hands, the wrists, the feet, the ankles. It can go other places as well. Usually it's symmetrical and it's systemic because it's the immune system that's driving inflammation everywhere simultaneously. Low-dose radiation to one knee is not going to reach the wrist on the other side. It cannot calm down a system-wide immune response. That's not what it's designed to do. So even if one joint feels better, the disease process that's driving all your other joints is still active and still needs to be addressed. So let me walk you through the conditions where the evidence is the strongest and work our way to RA specifically. For plantar fasciitis, there are European studies, trials showing meaningful pain reduction compared to placebo or sham treatment in chronic cases. In lateral epicondylitis or tennis elbow, there are studies showing improvement in chronic cases or ones that had not responded to anything else. What about knee osteoarthritis, which I see very commonly, almost as a secondary effect of RA or other conditions? The knee data, there are some controlled trials, but it's mixed. Some show that it helped and some show nothing at all. Bottom line is that low-dose radiation treatment is not fringe medicine. It is a real treatment. There is real research, especially for degenerative joint disease and chronic enthesopathy, which is the insertion tendons and ligaments on the body. But the data is strongest in those conditions and not in systemic rheumatoid arthritis, because RA is a whole body immune condition, and low-dose radiation, it treats a specific joint locally. So we don't have those large randomized controlled trials that we would like to see for rheumatoid arthritis. Hopefully they're coming. But sometimes with even RA, You might be well controlled on your biologic everywhere in your body, except one joint is bothering you and it's just out of control. Maybe low-dose radiation could be used for something like that because it's a local target, but we don't have large data on whether it'll help that or if it'll just help the pain part of it. And again, the radiation does not replace DMARD or biologic treatment. Absolutely not. And that distinction matters. This is a patient who has just completed radiation treatment for both of her knees. Take a look at the picture and you can still see a difference, right? There's asymmetry there. One knee is visibly larger than the other, but she told me her pain went down. And that matters because it's letting her be more functional day to day. She's walking more. But look at the swelling. It's still there. And that tells us something important clinically. Pain reduction and structural change are not the same thing. Structurally, they're still looking similar, right? There's still swelling, there's asymmetry. So radiation may calm down the pain signals locally without necessarily resolving the swelling or the joint changes. For her, this is important. She's unable to go to surgery at this point in her life, and so this is meaningfully helping her pain. But when a patient says they feel better, I want to see if both the pain and the inflammation go down. That's something for your doctor to follow. But in this case, I'm just happy that she feels better. Now let's talk safety, because I know that's been in the back of your mind ever since I said the word radiation. The doses used today are much lower than the cancer doses. Short-term side effects in the studies, they look like they're minimal, but we don't have decades of modern United States follow-up data. There is European data, but not so much over here. And historically, this is important. Radiation was once used for ankylosing spondylitis in a lot of people, 14,000 people, and they followed them. And they found in follow-up that these people developed cancer more often than other people. So they stopped doing it. But that was a higher amount of radiation, and it was often a larger field because they did the spine, because that's part of AS. Today's treatment is very different. It's much lower dose, and the field size is lower. But that history reminds us radiation is biologically active. Dose matters and long-term monitoring matters. It's just something we need to know. One more clarification while we're here. This is external beam radiation, which is different than radionuclide joint injection, because that one, radiation is delivered inside the joint directly. There are different procedures, there's different evidence behind them, different mechanisms. We are talking about external beam radiation. Remember, low-dose radiation has been working for people. It targets one area locally, so it's not for systemic disease, but it's a non-medication approach, which a lot of people are interested in because they either don't have a full response from their medication and they don't want to change it, or they can't take medication for some reason, or they have other conditions associated because you're allowed to. You're a human being. Hopefully more data will come out soon and we'll talk about it right here. And if you're interested in more non-medication treatment for rheumatoid arthritis, check out this video on vagus nerve stimulators, because that is now an FDA-approved treatment for RA. Hope this video helped you. Share it with somebody else who you think it might help, and I'll see you next time. Dr. Neha with Plant Forward MD.